Hi everyone, my name is Neil Tan, and I'm here to discuss neuro-sjogren's syndrome, an under-researched and poorly understood neurological variant of Sjögren syndrome, which is characterized by the immune system targeting and attacking the nervous system. Specifically, we will look into the neuroimmunological mechanisms of neuro-sjogren syndrome. To understand neuro-sjogren syndrome, we need a firm grasp on what Sjögren's itself is. Sjögren's is an autoimmune disease characterized primarily by its ability to induce dry eyes and mouth through damaging the exocrine glands, which are responsible for fluid secretion. Furthermore, Sjögren's has also been shown to affect internal regions like joints, kidneys, and of course the nervous system. In neuro-Sjögren's, the neurological component of Sjögren's syndrome, there are many possible complications for both the peripheral and central nervous system. Common symptoms include localized pain, numbness, fatigue, and brain fog, while rare cases have autonomic afflictions like dizziness or gastrointestinal problems. At the heart of many of the symptoms of neuro-Sjögren's lies one consistent cause across many studies: chronic inflammation caused by overactivation of the immune system and the lack of regulation. Chronic inflammation is characterized by the accumulation of inflammatory molecules that damage nerve fibers, alter signaling pathways, and exhaust neural repair systems. So what sets Sjögren's apart from any other autoimmune disease? Well, one of the defining traits is the type of autoantibodies involved. For neuro-Sjögren's, anti-SSA-Rho and anti-SSB-LA antibodies are the main propagators of neural and glial damage, inflammation, and progression of neuro-Sjögren's. The immunological response in neuro-Sjögren's is largely coordinated between T cells and B cells. The histological landmark for neuro-Sjögren's is a focal infiltration of T cells and, to a lesser degree, the presence of B cells to indicate chronic inflammation. T cells release cytokines while B cells produce antibodies. Together they form a cycle of immune responses. Many cytokines are implicated in neuro-Sjögren's as they are responsible for a variety of symptoms. Cytokines have been shown to be involved in the inflammation and the progression of inflammatory damage to nervous tissue and nerve fibers. They interfere with the autonomic function through dysregulation of cholinergic pathways and chronically stimulate B and T cells, leading to lymphomagenesis, the formation of lymphoma. Autoantibodies, lymphocytes, and cytokines all play a huge role in the cause, progression, and severity of neuro-Sjögren's syndrome. But how do these key players even make it to the brain? Normally, the blood-brain barrier protects the brain from immune invasion, but during neuro-Sjögren's, inflammation and cytokines disrupt the blood-brain barrier, allowing for infiltration to the brain to cause cognitive symptoms. Once the blood-brain barrier has been disrupted, other problems in the vasculature often occur. Ischemia, characterized by reduced blood flow and oxygenation, as well as vasculitis, characterized by inflammation-mediated blood wall thickening and damage, both lead to serious health consequences. Ischemia and vasculitis have been shown to lead to strokes and brain lesions, and is one of the suspected reasons for brain fog. Astrocytes are notoriously multifaceted in their involvement with different neuromechanisms. Similarly, in neuro-Sjögren's, they are just as involved. Cytokines like IL-6 and interferon gamma can activate astrocytes to release pro-inflammatory factors, which amplify local inflammation, weaken the blood-brain barrier, and disrupt neurotransmitter balance, resulting in heightened neural sensitivity. Normally, microglia, the central nervous system's resident immune cell, are responsible for cleaning up debris and removing pathogens. In neuro-Sjögren's, microglia are often dysregulated and chronically activated, leading to excessive synaptic pruning, oxidative stress, and neurodegeneration. There have been studies linking microglial dysregulation with cognitive decline in neuro-Sjögren's. As mentioned earlier, neuro-Sjögren's affects far more than just the brain. In rare but severe cases, transverse myelitis may occur. Transverse myelitis is characterized by focal inflammation in the spinal cord, leading to damage in either one or both sides of the spinal segment. While the exact mechanisms are unknown, research suggests that it's likely due to neuro-Sjögren's mediated vasculitis or demyelination. Moving to the peripheral nervous system, the most common symptom for those with neuro-Sjögren's is peripheral neuropathy. Peripheral neuropathy can be divided into large fiber, which causes numbness, weakness, and loss of balance, or small fiber, which causes burning pain and autonomic dysfunction. This debilitating aspect of the disease is directly caused by autoimmune response damaging nerve fibers. Not only does neuro-Sjögren's affect the central and peripheral nervous system, but it also has severe consequences for the autonomic nervous system. Small fiber nerve damage originating from inflammation and autoimmune responses damage the muscarinic cholinergic receptors, leading to the manifestation of orthostatic hypertension, which is low blood pressure when standing, irregular heartbeat, sweating, and dizziness. Now that we know the mechanism and symptoms of neuro-Sjögren's, let's discuss how neuro-Sjögren's is diagnosed. First, a diagnosis for Sjögren's itself must be positive, or the neurological components will be attributed to other forms of neuropathies. Possible Sjögren's diagnostic tests include blood tests for SSA-Rho and SSB-LA antibodies, the Schmier tear production test, and salivary gland biopsy. To diagnose neuro-Sjögren's, a series of neurological exams must be conducted on top of the positive Sjögren's diagnoses. Weakness in the toes and fingers greater than arms and legs is a sign of peripheral neuropathy. Further analysis can be done through nerve conduction exams or electromyography. For CNS involvement, brain and spine magnetic resonance imaging or cognitive testing may be conducted. While there is no cure for either Sjögren's or neuro-Sjögren's, there are therapeutic treatments to mitigate the effects of the disease. To suppress the neurological component of the disease, immunosuppressive therapies involving corticosteroids like hydroxychloroquine are often prescribed to minimize inflammation. For more severe cases, biological drugs like rituximab may be prescribed to target B-cell populations. While the current treatments are effective for some, many individuals suffering from neuro-Sjögren's continue to see their symptoms flare and worsen even with these medications. Luckily, there's still ongoing research with new drugs aimed to target cytokines like IL-6 and interferon gamma. However, the most promising current research involves therapies for restoration of immune tolerance through targeting regulatory T cells. Where do we go from here? Well, neuro-Sjögren's is a very difficult disease to study due to the symptom overlap with many other diseases like multiple sclerosis or lupus. Because of that, there's a high number of underdiagnosed cases of neuro-Sjögren's. We need better biomarkers, earlier screening tests, and more research into the mechanisms of how Sjögren's is converted to neuro-Sjögren's, as only a minority of patients get it. Neuro-Sjögren's is a prime example of the crossroads between immunology and neuroscience, as it demonstrates how chronic inflammation cascades into a plethora of neurological consequences. Only through understanding the role of lymphocytes, cytokines, and glial cells can we better diagnose, treat, and support patients suffering from this complex condition. Thank you.